Total contact casting is such a interesting topic because I think as podiatrists, we all know that we should be doing it and we should be doing it a lot more often than we do. And unfortunately, I think that a lot of that comes to maybe some office constraints or potentially time constraints, but it's definitely effective. I was just wondering, do you normally just graft the wound underneath your total contact cast, or do you frequently window out the areas where there's an ulceration on your total contact cast?
Well, can you hear me?
Yes.
Great. I say I probably use you're asking about grafting a wound versus windowing. I would say I very infrequently graft a wound because the cast is successful. I usually get my forefoot ulcerations healed up within a month. The 43 days that I stated in the studies is accurate. It really does occur that quickly. And if I don't, which is infrequent, then I move to a graft as needed, just like the Sheehan study said. If I'm not getting closure of a wound in a respective amount of time, then I'll move to grafting. Does that answer your question?
Yeah, I was actually wondering if you frequently window out. So if you have an ulceration, do you put a product on underneath of the cast and kind of just let it go for a week? Or do you window out the area with a cast saw so that you have access to do dressing changes to the wound?
I see what you're saying. No, I never window it only because that's access for the environment to get in there. And I certainly, I kid with my patients that I don't want my patients to touch my wound. This is my wound now. And the cast is that environment that keeps it safe from them, because that can be more of a problem. It's a closed toe cast, and that was on purpose. That was done back with Paul Brand in the treatment of Hansen's disease to keep the rats out, really. And so these casts, people often ask, why are the casts are closed on the toes? I give them that story about Paul Brand, but also because an open cast with a neuropathic patient is a nice shovel. And I live in Colorado, and that's a good place to get a lot of snow and debris in the winter, and then just environmental dirt otherwise. So no, I do not window my casts. I see them on a weekly basis. I debride on a weekly basis, and I've had great success with it. I've been doing it for 20 years now.
No, that's great. I think that maybe that barrier that we think that, it takes more time to do is potentially a false barrier, because these patients probably heal up faster and end up spending less time in your clinic overall.
I completely agree. Matter of fact, I published a little Podiatry Today study on, I timed myself and my two partners on how quickly did we put a cast on. And so the process in my office, and we do between 2 and 10 casts a day here. And I'll go in and I'll debride a wound, and then I'll leave. And my staff will go in and they will put the dressing on the wound, which is typically maybe an antibiotic ointment or a Medihoney or something, absorptive dressing, the soft goods. They'll apply the soft goods of the cast itself, and then I'll go back in, or I have a full-time pet orthopedist here who will go back in and apply the cast. And it typically takes about 7.5 minutes to apply a cast. They sit in the room and dry for 15 minutes before they walk out. Again, like you had mentioned, the wounds heal faster than average. Quoting again the study where if you do good wound care, they take forever to heal, and then you're exposing these patients to infection and subsequent amputation. So yeah, I think it takes a lot less time if you get accustomed with it. Of course, if you're doing one a week, one a month, it's going to take you longer. You just got to get your stuff all put together, and of course that takes a little bit longer.
I have a question. Do you do the traditional total contact cast or the easy contact?
David, I do both. In my private office, I do the traditional cast, probably because I'm a private office and it's expense related. I can put the cast materials together cheaper, and we've done it this way for over 20 years. In my wound care center, I like the easy cast because it is easy and the efficacy is good. Actually, I did a study on that too, where I put pressure map system inside the cast of both the traditional cast that we use and the EZ, and I found extremely similar offloading for the forefoot and the rear foot in both casts.
Oh, that's interesting.
Dr. Jacola, in regards to durability of both different types of casting, and knowing that we're putting the patient in the correct biomechanical position, obviously, you know, the ankle joint at 90 degrees, so we're not getting that breach when the patient is walking or getting that pistoning kind of effect. Can you talk a little bit about your experiences with the durability in regards to the different types of total contact casting with your experience? And you don't have to name brand names, just going over that.
So sure, the durability. The traditional cast, I think, is going to be a little bit more durable. However, I had a patient in today who's a heavy guy, and you know, none of our patients are heavy, right? So they walk a lot and they don't feel it. So what I will do with a traditional cast is, if they are breaking the cast, they'll break at the ankle or they'll break at the toe, I will add more layers, more fiberglass. And that's how I'll make a traditional cast more sustainable. I want to comment on the application, like you said, the biomechanics of this, and that the 90 degrees is extremely important. And all of the studies, the studies that I quoted in the lecture, are related to the traditional application of total contact cast. And that does really include that the patient needs to be on their face. Is that prone, supine?
Prone.
I always forget. Prone, with their foot up in the air, and you can really visualize and see the 90-degree angle of the foot. It's important because then when you bend that knee, you take the gastroc out of it, you get a much better ability to get that foot to 90 degrees. So I think that's really important. And even with the easy cast, the roll-on cast with the boot, I also do those in that position so that I can get an accurate 90-degree angle on it. Now, talking to the roll-on or the EZ type cast, the durability relies on the patient, because there's the outer shell or the outer boot that goes along with that, and that has to be on with every step. If it's not, then that cast is going to break and fail. So you emphasize that very significantly. I had a patient who had Alzheimer's, and he would take that boot portion off almost immediately. And so what I did is I took some fiberglass tape and I just taped the boot portion on so he couldn't get it off, and it worked. And so he healed up and got better.
So,
That's great.
Sorry, are there any patient you would not use a cast on? You know, like with the cast can be a huge height difference between the right and left limb, and oftentimes even like a young patient, they often come and complain of hip pain on the contralateral side. So for like older population who may have some hip arthritis or issue, do you tend to avoid putting casts on in those patients?
Obviously, you treat every patient as an individual, and yes, if there's a significant hip problem or frailty, 90-year-old patient that already had a fall, I'm probably not going to put that patient into a cast. There is a product called an Even Up that you put on the opposite limb shoe to bring it up to the height of the cast, and that I have several patients with that, and it's a cheap thing to get on Amazon. The other patients that I don't put into a cast would be, of course, infection, or they have inadequate blood flow, and we correct that first. And then finally, claustrophobia. A patient this afternoon, he has terrible ulcers, and I have such a difficult time getting them healed, but he absolutely cannot go in for claustrophobia reasons. No matter the medication I put him on to try, he just won't do it. I had a patient who had a fractured hip. Can't do that one. So again, it goes back to we're treating every patient as an individual, and you make that judgment call. To add to it, I have put 2 casts on a patient, one on each foot. And as long as they are a patient that that can handle it, I have video of patients that are in 2 casts and that can do it quite well.